Well, welcome everyone. My name is Susan Law. I'm an assistant professor at the University of Toronto and a senior scientist at Trillium Health Partners Institute for Better Health. And I'm very delighted to welcome you to the first long COVID webinar. And with apologies for this being a bit of an 11th hour event, we will become smoother as we move into a regular cycle of this. Our aim is to have one of these webinars a month with selected guests and scientists who are presenting latest research and findings and be open for discussion as well. So thanks. A few rules of engagement. We will encourage you to put questions in the chat as the presentations are moving along. And we will try to get to all, but we may ask that, some of them may be answered after the event, or we can address things as we go along as much as we can. If your question needs any clarifications, we may invite you to and we will enable you to unmute and turn on your camera if you would like to clarify a question. But otherwise, I will be moderating and selecting the questions as we go along. So thanks for joining us. Really appreciate it. We will be recording this and posting this afterwards. And thanks, Karen has put a welcome and the link to our website and the survey in the chat there. So great. I think we can get started. This is a 1 hour session. We're going to go ahead with 15 to 20 minutes for 2 different presentations, an overview of long COVID web by Dr. Angela Cheung, and an overview of the survey and results to date by both Claudia Lagacé and Scott McLeish. And that's the Canadian COVID-19 Antibodies and Health Survey, the CAS survey. So Angela, welcome to you. And Angela is the PI for Long COVID Web, national network of scientists, clinicians, and patient collaborators and others. And she's going to provide an overview of that. She's also a professor of medicine at the University of Toronto and a senior clinician scientist at the University Health Network. Welcome, Angela. Over to you.
Thank you. And I too want to welcome everyone to the inaugural sort of Long COVID Web webinar. And I'm going to just give everyone an update today of where we are at with Long COVID Web, and then pass it on to our StatsCan PHAC colleague for the second part. I just want to see if you can see this. Can you see?
Not yet, Angela.
Hang on 1 second. So let's try it one more time. Okay. Can you see this? Because I don't see anyone anymore, so let me know if you can see the slides.
Yes, it's all good. Thanks, Angela.
Great, thank you. I think many of you already know that Long COVID Web is really a network of networks. It's a research network supporting and conducting research in post-COVID condition, or what's commonly known as long COVID. And the vision is really to have a Canada without the post-COVID condition or long COVID. And our mission is fourfold. We want to accelerate the discovery and validation of Canadian-led science. We want to activate a learning health system that prioritizes the needs of individuals with long COVID. We also want to identify the best therapeutics and practices and accelerate access to care. And the fourth one is to maintain a vigorous surveillance system for the impact of long COVID. Now, we have been working hard on trying to achieve some of these goals. And many of you have seen this before as well. This is really sort of how our network is set up. It's around 4 different pillars of research: the biomedical team, the clinical team, the health services research team, and the population health team. And these 4 pillars are working together, doing cross-pillar work. And also, it's really focused on, I would say, patient and or person with lived experience centered questions. around how we can diagnose and assess, how can we manage and treat, and how can we access health and social services related to this condition. So this is a little bit on the network organization and governance. We have a steering committee. We have partner networks. There are many other networks that are working with us. And we also have a patient council. And these three groups are really what drives sort of the work of the network. There are also two other committees called the EDI, or Equity, Diversity, and Inclusion Committee, and also an Indigenous committee as well. So the work is really done in the middle by the pillars. Then we move what we have done to knowledge mobilization. And overall, we have an international advisory board, sort of advising on our activities. And we also have an executive committee and operations committee, the team that really move things along this continuum. So as of today, this is fresh. Thanks to Nick for providing these. We have 556 members, and many of them have international projects. And you can see sort of, many have sort of done, 162 people actually have projects, and some actually have 3 or more projects as well. And if we all wanted to look at sort of how it's divided, researchers make up about 190 members. We have a very strong long COVID patient membership as well, with 261, and a very strong clinician piece as well, with 102. So you can see that we are trying to increase the policymakers and and other people. So that's what's happening. So let me tell you a little bit about what we have accomplished so far. So first, we have established the teams, the working groups, the committees, and so these little, round circles, triangles, and these oblong shapes things are actually all filled with people right now. We have also set out our first 1 to 2 year priorities. We had a priority setting meeting in June, and this was what was decided based on everyone's input and voting. So you can see that they're divided into the 4 pillars with about 12 different priorities. We also have had a call for proposals. We've actually had 2 rounds. The first round was really on foundational grants. It's really things that need to be done in order for research to be done. And so we gave out 4 100K grant, 1 for each pillar, and the groups are working on those proposals and doing the work in those grants. It's also to really satisfy what we submitted to CIHR in terms of what we said we would do. The second round just closed last night, and we have received 19 proposals for 100K, 12 proposals for 50K, and 2 proposals for 25K. So these will be reviewed both by our patient partners as well as our scientific community, and hopefully we'll have some results at the end of December. So what I wanted to share today is really on the knowledge mobilization and communications piece. We've had regular town hall meetings to inform members of network activities, and we will continue to do that. Probably a little bit less frequently than what we have done previously, in order to inform people as to, calling people for the different membership in the different pillars. and other things that's been going on. Now that things are a little bit more settled, we will likely be having these as quarterly meetings. And we also have run annual Long COVID Web Network meetings. The first one was in Montreal in September 20th and 21st. And we partnered with FRQS on that conference. We gave out some trainee awards. And the second one is being planned in Alberta for October 2024. Now, the third one is really around the webinars. We want to update on the science on what's going on. So we are going to run monthly webinars and invite sort of experts to share what is the newest and latest on whatever topic related to long COVID. And this is our first one. And the last one that I want to share with you is that we're planning to have a across Canada ECHO, which stands for Enhancing Community Health Outcomes. And this is to educate healthcare providers and create a community of practice. This is being planned for a start date of January. So those are some of the things that we have been up to. You can see that on top of those, we actually, each team and working group and committee also have their own meetings. So for example, like the clinical pillar has been having meetings, the biomedical pillar has been having meetings. And so and the group that's working on sort of the core outcome set is having meetings. And so each group is actually working hard on producing what they said they would produce. So the next step for us is really to collate the new science over this past year. And so we're hoping to showcase that as well, so that people can see what has been accomplished, both individually and as a network. And I'm going to stop here and happy to answer any questions.
Thanks, Angela. That's terrific. Maybe because that was rather a quick overview, perhaps we can ask a couple of questions specific to Dr. Cheung's presentation now. One from Patricia here. Will these invitations go out to physicians and allied professionals such as nurses? I have seen many who've not heard of long COVID at all. Angela?
Yep, that's the plan. So we have good linkages with different organizations, both provincial and federal. Like, for example, the Canadian Family Physician, Canadian College of Family Physician, we're hoping to link with them for these ECHO seminars. And in Ontario, where I am, we are linked to the Ontario Family Physician Organization as well. So there are many different healthcare provider groups, including nurse practitioners, physios, and OTs, and other people as well. And so we are trying to see if we can create a community of practice.
Thanks, Angela.
And actually, in BC, so since you're from BC, in BC, we have they have run an ECHO from 2021 to 2022, and we are getting their help to set up this ECHO as well.
Great, thanks. And I'll take a couple more here. From Lynn, how do you make sure this work is not siloed? How do you ensure collaboration and insights and sharing across working groups?
That's a very important piece, and that's why we have these webinars, so that anyone inside Long COVID Web can attend. It's also for outside folks as well, but it's really trying to update the science, and we have meetings where people are sharing what's happening from one pillar to another. And I think having had some of these in-person meetings, it has really helped various pillars to understand the work in the other pillars. And this is really to try not to duplicate things. And when there's synergies, to get the groups together to work on them together. And I think out of this, we also establish new sort of connections and collaborations as well.
Thanks. So, and just to let you know that there is a patient advisory committee which meets regularly, and they are working through how to best invite people to and how to vet actually applications to join the patient advisory committee. And I'm sure there'll be more information about that on our website soon. Great. Just a note from Kathleen about how it's been challenging to acknowledge long COVID to the public. Thanks, Kathleen. And from Parag, not sure you're the right person to ask, but is there a reason why the government of Canada isn't doing all it can to fund as many studies to find out what treatments work as quickly as possible? The fourth year of COVID, and from my understanding, there aren't any treatments as yet. Angela, do you want to respond to that one?
Yeah, so long COVID and COVID in general reminds me of the early HIV days. So I was a trainee in the U.S. when HIV started, and so saw sort of firsthand sort of what happened, and there was a lot of stigma, there was a lot of misunderstanding, lots of disinformation and misinformation. And I'm seeing the same thing, but I think I do see a difference. The science has really moved much faster with COVID and long COVID than sort of HIV in the first 3 years, let's put it that way. And I am hopeful that there will be guidelines coming out on how we should treat how we should deal with some of the symptoms, et cetera, et cetera. And what I can tell you is that right now there are 4 very large trials. If you Google clinicaltrials.gov, you would see actually a lot of trials. And actually, one of the magazines, I think in Nature, commented that there's so many different trials and all of them are small. Are they going to make an impact on treatments of long COVID? And so, that was a very astute writer because with little trials, it's really difficult to make comments, right? So even when the trial is finished. And so, but I'm really hopeful in the next couple of years, hopefully we'll see results as well. There are 4 trials. Recovery in the US is one. Reclaim here is another one. These are platform trials. Revive is a third one, and WHO is starting one as well. So there are 4 fairly big trials, adaptive platform trials, looking at interventions for long COVID, from antiviral, addressing immune dysregulation and inflammation, addressing endothelial dysfunction, addressing many different things. And so hopefully in the next couple of years, we'll see some results to those trials as well.
Great, thanks, Angela. Last question for you, Angela. Just maybe you could talk about the response to a question from Malgorzata about where prevention fits within the pillars for long COVID web.
Oh, thank you for that. If you don't get COVID, you don't get long COVID, period, right? So you're definitely right about that. And I am hoping that we will get one of our ID experts to talk about prevention and for the next seminar. Which is really important. I mean, this is kind of the time to try to think about vaccinations. As the winter starts, the positivity rate has risen as well. And so like masking, I have my mask here. I just took it off and closed the door for this webinar. But hopefully for the next webinar, the person will present some data around the prevention piece as well. Prevention is really important.
And where does it fit within our pillars of working? I think that was the question.
I would say in the clinical pillar, but it really spans across all the pillars. It's not just one pillar, right? Because there's science on antibodies, and do the antibodies really cover the current variant? That would be the biomedical pillar. And then the clinical studies around people who are vaccinated, and do they get long COVID or getting other treatments in the acute phase, and the chance of getting long COVID. That's the clinical part. But there's also a health services research part and a population health part. So I would say it spans all 4 pillars.
Great. Thank you very much. I know there's more questions, but we do have to move on. I will now turn to Claudia and to Scott McLeish. Thank you. Claudia Lagacé is the Acting Director for the Lifespan Chronic Diseases and Conditions Division of the Health Promotion and Chronic Disease Prevention Branch at the Public Health Agency of Canada. And welcome to Scott as well. Scott McLeish, Assistant Director, Centre for the Direct Health Measures, Health Statistics Branch at Statistics Canada. So thank you both. Over to you.
Yeah, thank you for having us. I don't know, Claudia, if you wanted to start with something at the beginning, or if you want me to jump right into the...
Please do go ahead, Scott.
Okay, sounds good. So we can go to the next slide. So we're obviously here today to talk about the Canadian COVID-19 Antibody and Health Survey. This is a survey that really is a partnership between a few groups, and we'll kind of explain that a little bit. That's why Claudia and I are here presenting jointly, is that this really is a partnership between multiple entities, but very much FAC, Public Health Agency of Canada, and StatCan. On the StatCan side, in terms of health stats, there's a certain role that we try to play. We obviously are very experienced in terms of conducting population level surveys, but we also have experience with administrative data, looking at ways of integrating different data sources to be able to disaggregate the outputs as well. So we tried to play a few of these different roles with respect to this particular partnership. Next slide. So in terms of the survey itself, and I'll kind of explain that there is 2 cycles to this. We did conduct a first cycle early in the pandemic that was a little bit more focused on exposure risks. But the second cycle was really right from the inception designed to really better understand long-term experiences of Canadians after a COVID-19 experience there. So that was really the very beginnings of how we designed this, was to really better understand the symptomatic experiences, but also the impacts on the daily lives of Canadians as well. One of the pieces of this as well was we were also assessing the antibody levels in the Canadian population at that time, and trying to also look at acute infections in the population when we were in collection as well. And as kind of a broader picture was looking at how surveys like this could be done potentially more regularly to be able to monitor things like seroprevalence in Canada. Next slide. So I mentioned the partnership before. There were really 3 groups that were really key to that. So obviously Claudia is here representing the Public Health Agency of Canada, and I'm here representing Statistics Canada. And our other partner that was really key in this was the COVID-19 Immunity Task Force as well. So just wanted to recognize that. Next slide. So this is a survey that basically you have the kind of core elements there. We had a sample size of about 100,000 with representativeness across the 10 provinces. Our target population were those that were 18 plus. And we were really in the field from April through August of 2022. Next slide. So the way that the survey worked was, once we had our random sample of Canadians, they were basically provided a kit in the mail. There were a few different aspects to participating in the survey. So one was we had an electronic questionnaire, so they would be able to go on and complete the questionnaire online. And then we also had these biospecimen components, which was what we used to get at things like the antibodies. So there was a dry blood spot test, which was used to look at seroprevalence. And there was also a saliva sample, and we did a PCR test on the saliva sample to see if people are actively shedding the virus at that time. So after those were self-administered by respondents, they were mailed back. Laboratories then undertook the analysis to look at the different things that we wanted. And then finally, we were able to disseminate the results. And for us, because there's a biospecimen component to that, we also have the data that's stored in the StatCan biobank as well. Next slide. So I'll quickly cover kind of what we asked on the questionnaire itself. And then I'll kind of focus a little bit more on the long-term conditions and some of the brief results before handing it over to Claudia. So there was, at the very beginning of the survey, a fairly comprehensive overview of the history of individuals' health conditions in terms of diagnosed conditions, but also in terms of symptoms that they had been dealing with quite some time, even if they had not received any kind of diagnosis to explain those symptoms. Lots of temporal variables were really critical on this survey, understanding when did these things start and for how long, and the severity of them as well. So that was kind of a main component that was not specific to anything about COVID-19, but was at the beginning of the questionnaire. Then, of course, we did have a module that looked at their experience in terms of exposure to the virus and experience with a first infection. At the time that we were designing this, which was really in the fall of 2021, there wasn't a lot of multiple infections at the time, so this was something that we did not fully measure as part of this cycle of the survey. We did look then at a module on long-term recurring symptoms following the infection. We looked at their vaccination history, and then we also looked at some other topics like access to care during the pandemic, as well as a comprehensive socioeconomic profile of the respondents to allow for disaggregation of the results as well. Next slide. So when we were designing the modules of the survey, and as I said, that was really in the fall of 2021, we were really trying to make sure that we asked questions that would allow us to produce results that would align with the WHO definition. So really critically there was to understand if the symptoms, and we knew kind of some of the common symptoms at the time that were reported, the extent to which that those were taking place, and that they were at least 3 months after the onset of their first infection, as well as understanding how long, how persistent they were as well. Next slide. So this is kind of some of the questions that were very specific to those long-term symptoms. So as I mentioned, we really had a focus on the first infection. That was the kind of clear language that we had at the time. And so that was really looked at from the perspective of a first positive test. We did distinguish on the survey whether that was through kind of a PCR test or whether that was an at-home rapid antigen test. If they had never tested positive, then we asked, did you ever think that you had it? And there could be different reasons for that, such as I never tested positive, but everybody else in my household did, and I also got sick. So what was the point? So there was things like that that we were able to get at for that as well. We also had a third component, was even if they never think they had it, they had some unexplained symptoms that lasted for an extended period of time, coincidentally during the pandemic, and coincidentally symptoms that were more or less in line with what the WHO definition was there. So these were not, obviously there's no confirmed test to point that to, but it was important for us to at least get an understanding of those types of circumstances that could have been taking place in the population. We did look at the severity of the initial symptoms, and then we had a much more focus on the symptoms that were 3 or more months after infection. So things like, were they basically persistent from that initial infection, or was there sort of initial recovery and then symptoms kind of came back, or new symptoms emerged afterwards? They did specify the precise symptoms that they were experiencing. We had a list that they were able to select, but we also had empty write-in spaces that they could identify other symptoms if we didn't have them in the list. They explained the duration, and we also asked questions on the impact that the symptoms had on their daily activities, as well as if they had to lose days of work or school as a result. Next slide. So just some kind of quick results. Because we were in the field in that period, basically from spring through summer of 2022, this was a period of lots of activity in terms of COVID-19. So in fact, almost 2% of our respondents actually tested positive with a PCR test when they completed the survey, just to kind of give you a sense of how active the virus was at that time. And we also had this ability, because we were testing, because we were asking questions them about, do you think you've ever had COVID-19? We were getting a sense as well that there were lots of people who were currently shedding the virus, according to the PCR results, but actually had no idea that they had ever been exposed to the virus at that point in time. Next slide. And the antibody results were kind of another really critical piece to that. So at the time that we did that survey, almost, very, very high percentage of the population had some level of antibodies against SARS-CoV-2. That would be from vaccination as well as a previous infection. From a previous infection specifically, we had a seroprevalence estimate of about 54% at that time, and about 2 out of every 5 had never tested positive and did not think that they had ever had COVID-19. So just to give it a sense of the prevalence of the virus, that it was kind of flying under the radar for a lot of Canadians. Next slide. So in terms of looking at the results on the, what they answered, so by May, about 30% of Canadians had tested positive, and another 9.2% suspected that they had been infected by May. And then of that population, about 1 in 6 had symptoms that lasted 3 or more months after that initial infection. So giving a sense of, at that time, there was about 1.3 million Canadians that had had long-term symptoms following a COVID-19 infection, a COVID-19 experience. And the most common symptoms are listed there below. So fatigue, cough, shortness of breath, and brain fog were really the most common symptoms that were reported on the survey. Next slide. And so with that, I'll turn it over to my partner in this, Claudia.
Thanks, Scott. I hope everybody can hear me okay. Bonjour tout le monde. Really, thank you for having us present on our results today, especially given that this is the first webinar that the Long COVID Web is organizing. So really honored to be here with you. I saw in scanning some of the participants' name, I saw a few familiar names. So it looks like the whole Long COVID community is in attendance today. I do not have, unfortunately, the slides in French today, but I can take questions in French at the end. Ne vous gênez pas, ceux qui veulent poser leurs questions en français, je peux leur répondre sans problème. So before I start showing the some of our results, I just want to make a couple sort of preliminary remarks about them. So what I'm about to show are based on 2 publications that the agency released in the fall of 2022 and in the spring of 2023. Both publications are available online, so through our health info base. So they're easy to access, and throughout the deck, I've put the references to both publications, as well as the ones from Statistics Canada. Both publications are based on the 2nd and the 3rd provisional releases of the CCAS results. So this means that they were not, at the time, we were not using the final data because it wasn't released. But this was made possible by our really close collaboration with Scott's team and StatsCan that allowed us to provide some early signals to decision makers and to share national data out to the public describing the experience of people reporting longer term symptoms of COVID-19 in an as timely as possible manner. It's never fast enough, but this time I think we really tried to make the data available as quickly as we possibly could. And of course, additional analyses using the final data release are forthcoming on our end. So stay tuned for that, and we'll be happy to come back to present about those when they're available. Another thing I want to mention is that the analyses that are presented from here on are based on the share files that are received by the agency, the Public Health Agency of Canada, which includes only the respondents that have agreed to share their responses with us. So for those who didn't agree, we do not have access to their data. And as a result, it is possible that estimates may slightly differ from the results that are based on the master file that is held at Statistics Canada. So if you do see at some point some differences, this is the main reason. In the following slide, you will also notice that we refer to long-term symptoms of COVID-19 as opposed to long COVID or to post-COVID-19 condition. The reason behind this choice of terminology is really because that we didn't ask respondents to tell us whether they had been diagnosed with post-COVID-19 condition, but if they were experiencing symptoms following their COVID-19 infection. However, we consider that these symptoms do align with long COVID, and we, as Scott mentioned earlier, we did make sure to use the WHO case definition to identify the respondents who met the post-COVID-19 condition definition. So,
Sorry, Claudia.
Yes.
Just interrupting. Your slides aren't advancing. I wasn't sure if you hadn't intended that they were. Not yet?
It was intentional.
Okay, perfect. You said following, so I'm just checking. Perfect.
Thank you. So there you go. All right. So this slide is presenting some key demographics of those who reported experiencing long-term symptoms of COVID. So what we're seeing is that females were 1.8 times more likely than males to report long-term symptoms. We didn't note any sort of significant difference by age overall. However, the prevalence of long-term symptoms increased with age for females, going from almost 18% for those age 18 to 34 years to 24.5% for those age 65 years and over. Among males, the highest proportion was found in the younger age group, so among those age 18 to 34 with a prevalence of 13%. Long-term symptoms were most common among those who tested positive through a PCR test at almost 20%, followed by adults who suspected an infection at 15%, and then those who tested positive to a rapid antigen test at 10%. So the rise of rapid antigen tests and the changes in access to PCR tests during the less virulent Omicron wave may possibly account for some of these differences that we're seeing by manner of testing. We are not showing here on this slide the results for ethnicity and socioeconomic factors. They were not included in our initial publications because we really wanted to examine these populations in greater depth in future publications, and especially have the proper engagements with some of the specific subpopulation. So this is forthcoming, and it's not because we ignored that, but it's really just because we wanted to do justice to those demographics in particular. So this slide is showing that adults with more severe initial infection, such as those who were hospitalized or had severe symptoms which significantly affected their daily life, were more likely to report long-term symptoms of COVID. Adults with other risk factors, such as having a higher body mass index, reporting being disabled, or having one or more chronic conditions, were more likely to report long-term symptoms. On this slides, we have elected to present the number of chronic conditions versus specific chronic conditions in isolation. The reason behind this is that comorbidities may also be contributing to the experience of long-term symptoms. However, this information is available in our spring 2023 publication, but we are sort of suggesting that this data be interpreted with caution. We're seeing that close to half of the adults that reported a chronic condition prior to their infection had more than one chronic conditions. So comorbidities is definitely sort of playing a role in there. This slide shows the impact of the wave of infection and vaccination on reporting longer-term symptoms. This was a little bit of a tricky analysis for the team, but to be able to accurately ascertain the separate impact of the emerging variants and of vaccination status on longer-term symptoms, while as well acknowledging the limitation of the sample size. The pandemic period was broken down into 4 meaningful intervals, which we are hoping capture the growing proportion of vaccinated adults and the emergence of the Omicron variant. Those periods were January 2020 to December 2020, January 2021 to June 2021, July 2021 to November 2021, and December to May 2022. And we sort of stopped at May 2022 to allow for the 3 months of follow-up prior to August 31st, 2022, which is sort of the end of the data collection for the survey. So on the left-hand side of the graph, we see that adults that had their COVID infection during the period of July to later were less likely to report long-term symptoms. This could potentially suggest that vaccines may have had a protective effect prior to the less virulent Omicron wave. We're also seeing something similar in the literature. So our survey results would tend to align with what is being reported in the scientific literature, but that is a topic that requires more research, obviously. And on the right-hand side, we can see that adults who received two or three COVID vaccine doses prior to their infection were about half as less likely to report long-term symptoms as unvaccinated adults. So these slides cover central aspects of the impact of long-term symptoms or of long COVID on people's life. We're seeing that early evidence are suggesting that long COVID might have a notable economic impact through increased healthcare costs, loss of productivity, or return to work, in addition to profoundly impacting quality of life of those who are affected. So in our October 2022 report, we specifically looked at these impacts. And we found that more than 1 in 5 adults with long-term symptoms were often or always limited in their daily activities by their symptoms. That among adults with long-term symptoms who were employed or attending school, 74% had missed 1 or more days due to their symptoms at the time of completing their questionnaire, and that on average they missed 20 days. Also, among adults who ever experienced long-term symptoms who were infected a year or more in the past, close to half reported that their symptoms lasted 1 year or longer. This slide shows the association between long-term symptoms and self-rated health measure. So adults with continuing long-term symptoms were 4 times more likely to report fair or poor overall health, and almost 3 times more likely to report fair or poor mental health compared to those who never reported long-term symptoms. In addition, adults with resolved long-term symptoms had health ratings comparable to adults who never reported long-term symptoms. However, since self-rated health was not assessed prior to infection, it is not known based on these data whether fair or poor self-rated health or self-rated mental health is a risk factor for or a consequence of the longer-term symptoms. So we're unable to disentangle that aspect using the data. So some analytical considerations. I think Scott went over some of them earlier in his slides, but I think it's important to mention that CCAS was designed in accordance with Statistics Canada's quality assurance framework, and also meets Statistics Canada's high standards for data quality. And we've worked really hard, both our teams have worked really hard together to really make sure that data quality issues would be identified and corrected before the data would be released. As there are many questions that require respondents to provide dates, and Scott alluded to that as well, the temporal nature of many of the questions included in CCAS will have an impact on the complexities of the data set and its analyses. We particularly sort of focused on identifying respondents who met the case definition, and sometimes the follow-up time since the start of the pandemic or the date of infection varied across respondents at the time of questionnaire completion. This was sort of complicating our analyses on the duration of symptoms and factors that could be associated with recovery. So these are just a few examples. And there's also to keep in mind whenever analyzing cross-sectional surveys based on self-report, we always have to be mindful of the sample size that we have, and sometimes this is creating some challenges when we want to disaggregate our data further. Yeah, so there's also non-response, the accuracy of response and the impact of recall. We're asking for a lot of dates, and sometimes we can see some funny things going on, but it's nothing that cannot be sort of addressed or corrected. There's the social desirability bias, as with any surveys, and also, again, as with any surveys, an inability to establish causality. So this ends the presentation of the select results from our published work. As I said earlier, those results are consistent with the current state of the knowledge on long COVID. But I'm sure that this group can sort of speak much better than me to that effect. But there's still a lot of work that needs to be done for us to improve our understanding of long COVID. This slide is showing some forthcoming work that FAC and StatScan are working on right now. So building on the CCAS Cycle 2, FAC and StatScan, we developed a follow-up survey that was conducted between May 2023 and June 19, 2023 to further measure the impact of long COVID over a longer period. The data captured in that survey include the reinfection. So this is an opportunity for us to measure that, which we were unable to measure in the first one. Use of prescription medication specifically developed for the treatment of COVID-19. We're looking at the employment sector of the respondents, the use of disability benefits or workers' compensation, and healthcare use for symptoms. And the two surveys will be linked together, providing a very rich data source for more detailed longitudinal information about long COVID that is needed to address some of the existing data gaps that are still prevailing. I'm now going to turn back over to you, Scott, for the last few slides.
Yeah, in fact, I saw a question in the chat there on how the data could be accessed and stuff like that. So everything that we collect at StatCan ends up being made available to the research community through the research data centers, which are across Canada, and that's no exception in this case. I mentioned early in my slides, we do have a StatCan biobank. That's kind of a very specific process if it were to be for accessing the dry blood spot results, for example. But the microdata itself, it really is a very rich data source, and there are definitely limitations, but there are lots of ways to look at this data in different types of analytical ways that Statistics Canada and Public Health Agency Canada have not on. And so it would be quite wonderful the more people that can access this data and see what value they can draw from it. So just want to kind of plug that as well. We of course have some basic results on our website in terms of some basic tables, and Claudia mentioned earlier that some of the analytical reports that have been produced either on the Public Health Agency of Canada website or StatCan's website will be available as well. And just kind of a final acknowledgement that I mentioned the partnership, with Public Health Agency of Canada and COVID-19 Immunity Task Force before. We also had a lot of help from the labs that did the lab analysis of the biospecimen component. So it's just a little bit of an extended acknowledgement there. Thanks.
Right, excellent work. Thank you so much, Scott and Claudia. We do have a number of questions, and perhaps I'll just start with the one about, actually there's a few that relate to this, about who might not be in the sample. So those that don't seroconvert or serorevert, or who may not.
I think Susan is frozen, but maybe you can answer there. Susan, sorry, I just sort of chimed in because you disappeared for a little bit. You were frozen for a little bit.
Oh, sorry, I didn't realize.
Well, I can quickly, just to kind of quickly address those ones. We worked very closely. That was a main role of the COVID-19 Immunity Task Force in providing some guidance in terms of how to approach the analysis on the antibody results. So we work quite closely with them on that aspect. But just to kind of be clear, from a sample perspective, the survey didn't exclude anyone based on the results of any of those tests. And in fact, we have respondents that were part of the survey that did the questionnaire component, but did not want to participate in the dry blood spot test as well. So there's different ways of analyzing the data set as a result of that. But just to be clear that there was no one was dropped from the survey simply because of the antibody testing.
Yeah, and Scott, just to also perhaps reiterate it at the beginning, you mentioned that it included only the 10 provinces. So unfortunately, we were unable to do the data collection in the territories. So the 3 territories wouldn't be part of the sample for the survey, and of course, children aged less than 18. We were not able to include them. So unfortunately, Susan and Angela, I'm going to have to leave as I'm expected at another event, but just really want to thank everyone for joining and listening. And as I mentioned to Susan, the questions that Scott cannot address can sort of be collected and sent my way, and I'll do my best to answer them. Thank you so much.
Thank you very much, Claudia.
My apologies for leaving early.
It's okay.
Bye-bye.
You can do what you can do, but we really appreciate your time with us. Thank you.
Thank you.
Great. Good. So if I froze, it's possible that I've missed a couple of questions. So Angela, jump in if there's something I've missed. But I think that, I don't know if you want to add anything to any pediatric surveys that may be complementary to this sort of data.
That was one of the questions that came up, Scott. Are you planning to do a pediatric survey under 18?
Yeah, at this time, we don't have a current plan for a survey that's beyond the one that Claudia mentioned, the follow-up panel that we've done. We don't have any current plans for an additional survey at this time.
Yeah.
It's not to say that we can't. It's just to say that currently there isn't something kind of on the books there for the next little bit.
Okay, great. Thank you. Good.
And while Susan is looking, Scott, I think there was also another question around what antibodies were tested by that dry blood spot.
Yeah, so we looked at it's been a bit of time there for me to kind of fully remember there, but there were the three kind of standard types of antibodies that we tested for. But
So
yeah,
the usual three that I know both Mark Lanloy and Claude Gingrist do are the spike antibody,
Yeah.
The RBD, the receptor binding domain, and
And
also
nucleocapsid.
the nucleocapsid.
Yeah.
And so if that's what they do for this study, that's usually what they do for all the various studies, but just want to double check that. Yeah.
What I could say is like one thing that was a bit different, at least there are studies that did the same thing as us, but just to be clear too, that we didn't have a qualitative result. We actually had a quantitative result from those tests. So that does allow for some potentially more complex analysis as a result of that as well. And then obviously there was kind of this critical question of are those antibodies the result of an infection or vaccination? And so again, we worked quite closely with CITF on looking at how to address that. Because so much of the population had at least one vaccine at the time that we were in the field, the nucleocapsid result was really critical, was really kind of the main driver behind that particular statistic. And I saw some other questions in terms of the complexities and stuff like that. I think we could probably spend a very long time talking about that. And just looking at the kind of time, just to kind of say that I can post the full questionnaire so people can see. I saw some questions about like the comorbidities and how things were collected in terms of chronic conditions and stuff like that. So we did actually have a main list of conditions that last at least 6 months or longer. Like somebody was asking about whether includes kind of eczema and stuff like that. In theory, they could put them, and they were asked subsequent questions for each particular condition. But something like eczema, for example, wasn't one of the main ones listed. They would have had to have written that in. But yes, in terms of, I'm pretty sure that in Claudia's analysis that she wouldn't have gone in and distinguished between the types of conditions that respondents would have provided.
Thank you. I think one more question we'll sneak in is just from Dawn. What's the current thought regarding PCC patients and the new vaccine? Is there any risk of worsening existing problems from your perspective? Angela, maybe?
I'm not the right person to ask that question, I guess. So I can certainly speak to kind of how we went about collecting the data and some of the things that we saw in terms of the results, but I wouldn't be the right person to ask a question like that. Sorry.
So I can make a general comment and tune in our next sort of seminar as well to talk to the experts about this. So the general comment is that COVID is here to stay. It's not going to really totally disappear. And so it's important to think about maybe doing something similar to the flu vaccine and getting updated every year. And if you have had a COVID infection or a vaccination longer than 6 months, then you would be eligible for getting the new vaccine when it comes to the market, to the Canadian market. And actually, researchers are actually moving towards getting a one-dose vaccine that covers flu, RSV, and so RSV is another respiratory virus that is quite common, and COVID together. But this fall, we're not going to see that. RSV vaccine is recommended for age 60 and over, and also younger kids. And it's actually on the market right now. So I've already written one prescription for someone for the RSV vaccine.
Thank you, Angela. That's great. So I think we're at time now, but I just wanted to say thanks, everyone. Thanks to our speakers. We will follow up on whether or not we can share the slides, and there will be a posting of this recording on our Long COVID website. Thanks so much. And we'll see you again. Our next session will be on November 14th at this time. Take care, everyone.